Well, good evening, ladies and gentlemen. Good evening, brothers and sisters. Good evening. We are so happy that you are here with us today. We're excited and we are so glad that we can have this opportunity to be able to come together today on this platform, in this forum, to be able to go over some things that I think are necessary and some things that are helpful for us, especially in our community. And I'm so thankful today that the Lord has enabled us and that we have a wonderful panel that will be sharing with us today. And I'm so thankful for them taking their time, these awesome panel of doctors. We're so grateful to them. We'll be hearing a little bit more about them in a little bit. But a very special thank you to Dr. Reagan, Dr. Ruel, and Dr. Odidina. We are happy that you were able to take time out of your busy schedules and to be with us today to share with us some pertinent information and some information that will be extremely helpful to us as we fight this pandemic. So I would like for you to bow your heads with me as we go into a time of prayer. We just want to pray for a minute, and then I'm going to be turning over to Lady Aretha, who is a member of our medical team, and she will be introducing our panelists today and telling us a little bit more about them. So let's just bow our heads in a word of prayer, and we will move forward from there. Father, we come before you today. We thank you, oh God, for your blessings. We thank you, oh God, that this is the day that you have made. We will continue to rejoice and we will be glad in this day. Thank you for this time that we can come together, Lord, to receive information that will be helpful to us, that will be helpful in our journey as we continue to fight this pandemic. I pray that you will open up our hearts, open up our minds, our spirits to receive today, Lord God. Thank you for the doctors, Lord God, who have taken time to be with us. I pray that as they share the information with us today, oh God, that we will take it to heart and we will learn from it today. I ask your blessings in the name of Jesus. Amen and amen. So at this time, I'm going to turn it to Lady Aretha, and she's going to introduce our guest and our panelists this session.
Hello, everybody. It is so good to be here. Today, I want to give an apology on behalf of Sister Sherry, who is our medical team director. She had to work today and she is a nurse. So that's one of the things that we have to deal with, especially in this pandemic. She is a nurse, and so she was unable to be here to introduce our panelists today. We are here because we need to educate ourselves. There are a lot of misinformation out there regarding COVID, regarding the COVID-19 vaccination, and even just basic statistics. And so, what we're here today to do is to just give some information so that as we make decisions, we can make decisions in the right way. We can say, okay, I'm not doing this because of this, or I'm going to do this because I am even that much more educated. So that's what the medical team of District 1 is here for. This morning, I'm going to introduce Dr. Gary Rule, and he's going to give us some information on COVID-19, the disease. And Dr. Gary Rule is an internal medicine physician and public health practitioner. As a former director of health and human services in Hartford, Connecticut, he was responsible for the management and operation of the public health department, a role that included implementing federal and state public health policies and programs, developing plans, policies, and programs to address the city's public health and human services need. He is also an author and mental health advocate. He has a broad perspective in healthcare gained by personal, professional, and volunteer medical missions in the Caribbean and Africa. He is active in the community and has served on the board of several nonprofit organizations, including the National Alliance on Mental Illness, Connecticut chapter, the Jacob L. and Lewis Fox Foundation, the West Indian Foundation, and the West Indian Social Club of Hartford. He has appeared on local and international television, speaking on several healthcare topics, including mental health parity, medical tourism, healthcare trade and investments, and innovations in healthcare. To learn more about Gary, please visit www.garyrule.com. You may also find him on Twitter at Gary Rule, on LinkedIn, and on Facebook /Gary.Rule.1. Please welcome one of the professionals, one of our subject matter experts, Dr. Gary Rule. You can go ahead, Dr. Rule.
Oh, hi there. Just saying hi to everyone, and thanks for having me on the panel.
It's good to have you. So good to have you. I will introduce each right before you come on. So you can go ahead, Dr. Rule.
Oh, okay. I wasn't sure. Okay, I'm sorry for that, Sister Kaylee.
No problem.
Right. So as Sister Kaylee said, I am going to take the next 15 to 20 minutes and just kind of give you a very broad overview of what COVID-19 is. And hopefully that will make the case about why the other speakers will speak to you about COVID-19 vaccines. I'm going to share my slides. It's probably just about 20 slides that I'll go through, but it should take only about 15 minutes. So if you just bear with me for 1 second, if I can share my screen. And you should be seeing some slides. Are you seeing the slides?
Yes.
Okay, so very fast, just to kind of bring everyone up to the same level of understanding, and you probably have lots of questions after. I'm going to talk about COVID-19 and the complications specifically called long COVID. This is what the COVID-19 virus looks like. So when they talk about the virus, you see that round glob of stuff that's there, and then you see those spikes that's coming off. Those are called the spike proteins. So welcome again, District 1, Church of God of Prophecy. Thanks for having us and having me specifically talking to you. So I wanted to just kind of level set so we know why we're concerned about this global pandemic. I pulled some data from Johns Hopkins and the CDC, just so you have an idea of what the impact of this infection has been. Across the globe as of today, February 13, there were about 108 million infections across the globe, with 2.3 million persons who have died. In the US, 27 million persons infected, with 481,000 persons who have died. And then in Florida, 1.84 million infections, with 28,565 persons who've lost their lives, with a positivity rate of about 8.76. A pandemic, a problem for really every one of us. This specific slide speaks to some of the populations that we're really concerned about. Specifically, if you are American Indian or Alaska Native, if you are Black or African American and or Hispanic. And it's a busy slide, but basically what it says is that if you are Black, African American, Afro-Caribbean, and or Hispanic, you are about 40% more likely to have an infection, or 1.5 times that. About 4 times the risk of being hospitalized, and about 3 times the risk of dying from this infection. If you are Hispanic, it's about 4 times. So this is why, for us and for this conversation, we really want to highlight the problem with COVID-19 and the fact that specific populations are at increased risk, specifically for hospitalizations and for death. Later on, we'll talk about why we're suggesting the vaccines, because we know vaccines will save lives. Okay, so to kind of go back a little bit, what is COVID-19? It's a severe acute respiratory syndrome caused from a virus, coronavirus. It's also called SARS-CoV-2. It's the virus that causes COVID-19, and it's an RNA virus. In the Q&A, we can talk about that again. So just to kind of level set, it causes a severe respiratory syndrome. It's newly recognized. It's never been seen in humans before. In the US, The reports really came out about the 21st of January of 2020. So we're dealing with this infection for about 387 days. It's novel. We're still learning about it. And so you might say, some of the reasons I think why people have questions constantly are that sometimes the recommendations that we made are going to be changed, and that's only because we're learning more and more as we go. What's not going to change? The main way you get this infection is by it infecting your respiratory tract. Respiratory droplets, it's airborne. You get infected through your nose, your mouth, your eyes, and your lungs. That's not going to change. In terms of symptoms that you have from COVID-19, you get a couple of different things: fever, cough, shortness of breath, difficulty breathing, chills, muscle pain and aches, a headache, a sore throat, a new loss of taste or smell, congestion or a runny nose, nausea or vomiting, and some diarrhea. Those things really have not changed. And some folks might say, well, that reminds me of the influenza. It is typically like a viral infection where it causes this constellation of all these things, but it's a lot much more severe than just getting a bad flu. Typically, the symptoms appear 2 to 14 days after exposure. And as I just showed you before, there's a wide range of symptoms, but primarily it's going to be respiratory. In your lungs, coughing, shortness of breath, difficulty breathing. The symptoms can be mild to severe. If you develop symptoms and think you've been exposed, what we really want you to do is consult your healthcare provider, and you must do that immediately. And so when should you become alarmed? You should become alarmed if you have these symptoms: trouble breathing, persistent chest pain or chest pressure. If you find that you can't stay awake, you're falling asleep, that probably means that your oxygen level is falling. You're having new confusion. You can't concentrate, you can't think. If your lips turn blue or your face is becoming darkened, again, a sign that you're not taking in enough oxygen in your body. Who is at increased risk? Obviously, older persons 65 and older, 75 and older, person with a chronic medical condition. Specifically, anyone with serious heart disease, high blood pressure, heart failure, previous heart attack, emphysema, diabetes, obesity, being overweight, any lung problem, if you smoke, sickle cell disease, if you're pregnant, if you have a weakened immune system for any reason, a previous transplant, HIV, other cancers that you've been exposed to, these will increase your risk. And so just think about those things specifically that puts you at risk. Part of the issue for persons who are African American, Afro-Caribbean, anyone who's Black, the burden for us for having high blood pressure, diabetes, lung disease is very high, coupled with the fact that the access to healthcare that we have is somewhat impacted and crippled. So the numbers when we talk about we are at risk for the infections, hospitalizations, and death, it's a combination of several different things, and we can talk about that in the Q&A. And I'm almost done. But just remember, this infection is by it's a respiratory problem, respiratory droplets. If you cough, if you sneeze, if you talk, if you sing, you're most likely going to be putting out those viruses in the atmosphere, and somebody who's close to you, sitting by, standing, or singing with you, they can become infected. It's also on surfaces. So once these droplets land on surface and then you touch your mouth, your nose, your eyes, it's going to get into your airway. So these are why we make the recommendations that we do. This is just a really fancy slide to show you that it's really all over the globe. And the red spots are just where it's really, really high. So how do we stop the spread of COVID? A lot of infections, global pandemic, in the US, In Florida, the way that we prevent this, it's respiratory. Stay at home as you've been advised by your public health persons. We know over the last 14 months, wearing a mask properly, making sure it covers your nose, your mouth, and is thick under your chin, that makes a difference because that saves lives. If you have to cough and sneeze, do so in your elbow. Staying 6 feet apart, social distancing. And if you can do much more than that, you should be doing those things. Sanitizing by washing your hands, soap and water, 20 seconds, doing that vigorously. If you don't have access to soap and water, you can certainly use your hand sanitizer, but then the first chance you get, make sure that you go to the sink and wash your hands. Avoid touching your eyes, your nose, your mouth, any part of the upper airway system where you can get yourself infected. Cleaning really just means using soap and water for surfaces. Anywhere that's touched frequently, be sure that you clean them and then you disinfect, right? So whether that's with a Lysol or a diluted alcohol solution, or if you go to the EPA, there's a whole bunch of chemicals that you can use to disinfect. And of course, if you need medical care, because of the risk of infecting others, be sure that when you call 911, you tell them you think you might be exposed to COVID, or if it's your healthcare provider, so they can advise you about when you come in, how to call, and so they can be prepared to really make themselves also be prepared when they're going to be treating you. I'm almost done. Who should not wear a mask? Children younger than 2 years old. Anyone who has trouble breathing. Anyone who is unconscious, anyone who is going to have trouble taking a mask off, they shouldn't have a mask on. But really, everybody else should be masking. And you probably have heard, we're kind of strengthening the recommendations that we do to you, that we give you. Probably one mask is not going to be sufficient because now we're seeing variants or different strains. You've probably heard about the Brazilian strain, the UK strain. There are a couple of others, and I'm missing them right now. UK, Brasilia, South Africa strain. Those are, you can assume that they're actually here in the US, and whatever state you are in, it's already here. So you have to create that barrier between yourself and somebody else who potentially is going to infect you, right? So a mask, probably 2 masks, and doing the other things, social distancing, hand washing as we recommended. The other speakers will talk to you about vaccines. Vaccines saves lives, and that's going to be another recommendation. Just a nice picture again of what the COVID virus looks like with the spike proteins coming off of them. The diagnosis, you probably know how that's been made. Basically, you'll have the symptoms, the sore throat, the fever, the chills, and you've seen the many, many pictures of folks getting their nose swabs done, but you can also do that by a throat swab, or if you're coughing, probably by phlegm. Last couple of minutes. Why am I passionate about telling you about COVID-19? Most people who have COVID-19 will recover. But we're seeing a problem called long COVID, the complications of COVID that last for a long time. And those things specifically are people have fatigue, shortness of breath, cough, joint pain, chest pain that last for a long time. Specific organs that are affected, that we know are affected for long COVID, your heart. So even for persons who've had mild symptoms of COVID-19, when we've looked at some of the heart images of persons who've had COVID-19, we recognize that they have heart damage. And this will be a risk. Even if you have mild COVID-19, we believe that this will be a risk for heart failure or other heart complications in the future. How do we know this? Because there have been other SARS, severe acute respiratory syndrome, that you've probably heard about before. There's been one in Asia, and there's been one in the Middle East. So just looking back on what that's done for the persons over the long term, we know that this is a problem, not only because of that, but also because of what we're seeing with COVID-19. It affects your heart long-term. It affects your lungs long-term because the type of pneumonia that COVID-19 causes, as your body appropriately tries to fight this infection, typically what it does, it causes a lot of scarring. So you get a lot of scarring in the tiny air sacs in your lungs. That scar tissue should not be in your lungs. So typically what we're seeing, people who have long COVID, they end up having problems with those scar tissues, and they'll end up having long-term breathing problems. So that's the complication. I'm going to talk about two other organ systems, the brain. So persons have had strokes, even if you're young. They've had seizures. They've had something called Guillain-Barré syndrome, which is a temporal paralysis where you can't move your hands and you can't move your legs, and you become paralyzed. There's also the belief that because of the infection, even if you've had mild COVID, because of what we've known from previous infections like this, there is the thought that it's going to increase the risk of developing Parkinson's disease as well as Alzheimer's disease. You don't want this infection. You don't want this infection. So when the other two speakers talk to us, what we are, and myself, is trying to say is, we need to use everything in our toolkit to prevent an infection. You don't want a mild infection, you don't want a severe infection, and we certainly don't want any of our persons, no one, to lose a family member from this disease. Two other systems that are affected. So COVID-19 causes a lot of clumping of blood cells and forming clots. And it does that in specific organ systems. In your heart, persons have had heart attacks, they've had pericarditis, they've had strokes, as I said before. You might have heard of the Broadway actor who had, it affected his legs, where he had to have amputations of his legs and of his digits, actually lost his life eventually. Clots in your liver, clots in your kidneys. So even after you've recovered, there are persons who are on dialysis because of COVID-19. It weakens the blood vessels. It's just a terrible disease that we, as a healthcare provider and as a family member and somebody who's concerned about the community, this is something that we don't want to see you have at all. Finally, it's good that you're talking about to a spiritual community, right? So COVID-19 affects you spiritually, physically, but it also has some mental health issues, and there are a whole number of them. For persons specifically who have been in the ICU, on a ventilator, cut off from their loved ones, people can't visit, your loved one can't visit, you have a healthcare provider, a nurse, a doctor, putting up a Zoom, putting up FaceTime so you can actually communicate with your family, that's traumatic. That's very traumatic for the person going through that. So what we're seeing are persons going through post-traumatic stress syndrome. And that's just a fancy word for the stress that you feel after you've gone through a major life-changing event. We're seeing increased rates of depression, anxiety for persons who have gone through this illness, not to mention their family and the healthcare providers as well. But based upon what we know about the effect from previous SARS infections like the Middle Eastern one and the South Asian one, we know that this is definitely going to be a problem. Persons have also had complex syndrome, something called chronic fatigue syndrome. And that is, again, people get, they can't function even when they rest. Even when they rest physically, it doesn't help. It's chronic, and they just don't get better. So acute infections of COVID is problematic. The long-term effects of COVID-19 are problematic. This is something that we don't want you to have. And I'm just going to go to my last slide. That just kind of shows you again the image of COVID-19 and the spike proteins that are there. And I'll stop and turn it over to Sister Kaylee.
Thank you so much, Dr. Rule. Thank you so much. Wow. I've heard my coworkers. As a nurse, I have a friend who is a nurse. Her husband is a firefighter, 40-something years old, and he is still on oxygen, and it's been months later. I've heard of the post-COVID fatigue, that it is real, from my coworkers and family members as well. And I also had a family member pass away from the blood clot post-COVID. So this is real information, very real information. Thank you so much, Dr. Rule.
Thanks.
We are now going to get additional information on the coronavirus vaccine from Dr. Ragan. I will say, if you'd like to, you can go ahead and write your questions in the chat, and so that we can then follow up with the physicians towards the end. Please go ahead and do so, and we'll make sure to read them and follow through with them. So Dr. Camille Ragan is a professor in the Cancer Prevention and Control Program at Fox Chase Cancer Center, Temple University Health System in Philadelphia. Her research focuses on cancer epidemiology and prevention, primarily in Black populations. She earned a PhD in infectious diseases and microbiology from the University of Pittsburgh Graduate School of Public Health, and completed her postdoctoral training and MPH degree in epidemiology as part of the NIH NCI-funded Cancer Education and Career Development Program in the University of Pittsburgh Cancer Institute. Her research focuses on the molecular epidemiology of cancer in the African diaspora. In 2006, she established the African Caribbean Cancer Consortium, AC3, a research group designed to promote collaboration between cancer researchers who focus their work on the African diaspora. This research group supports collaborations in women's cancers, prostate, upper aerodigestive tract, and colorectal cancers. Recognizing the public health significance of cancer in populations of African origin and sociocultural factors that influence disparities in health outcomes, she has fostered collaborative research by leading numerous multinational pooling data initiatives to examine genetic, molecular, and environmental contribution in carcinogenesis among populations of African origin. She is the recipient of a number of NIH and foundation grants and is an American Cancer Society Research Scholar. In 2016, Dr. Ragan received the Cancer Control Award from the American Cancer Society, Greater Philadelphia area. She is also a recipient of a strategic planning grant from the National Cancer Institute to establish a Caribbean Regional Center for Research Excellence, focused on cancer research in the Caribbean. She is PI of the Cancer Prevention Project of Philadelphia, CAP3, a multicultural community-based cohort consisting of US and foreign-born persons of African descent. She is also PI of an international cohort in Jamaica, which focuses on cancer and cardiovascular disease risk. Her research program focuses on lung, head and neck, prostate, and cervical cancers. Please welcome today Dr. Camille Ragan, and she will be giving us information on the coronavirus vaccine. Welcome, Dr. Camille.
Thank you very much for that kind introduction. I'm going to dive right into the slides. So today I will be providing an overview of the virus itself, the coronavirus, and also the vaccine. First, I'll actually talk to you a little bit about the coronavirus family and the SARS-CoV-2. We'll talk briefly about how someone's immune system is able to fight an infection, a type of viral infection. Then I'll go into the COVID-19 vaccine. I'll talk about what the vaccine is and how it works, and also provide some comparisons between this particular vaccine, which is the mRNA vaccine, and versus the conventional vaccines that we've had over the years. I'll also present some results from the efficacy trials, particularly the Pfizer vaccine trials, and then close out with key facts about the COVID-19 vaccine and the tips on what folks need to think about if they choose to be vaccinated. So briefly, for those that may not be aware, coronavirus is actually a family of many viruses. And these are viruses that are typically referred to as enveloped RNA viruses. And the picture here on the right shows you schematics of what a coronavirus looks like. And of course, as Dr. Rule has pointed out, these spikes that you see on the surface of the virus, this is the particular protein that the virus uses to enter a cell when it infects an individual. However, coronavirus causes disease in mammals, including humans, as well as even birds. But primarily these viruses are respiratory tract infections, and it can range from mild to lethal. Mild illnesses in humans usually are typically the common cold in terms of symptoms. And of course, there are more lethal varieties of the coronavirus, one of which we now know is COVID-19. And of course, it was referred to by Dr. Rule, the SARS and MERS viruses. Those are also coronaviruses. So coronavirus in general is not new to us, although the COVID-19 virus is novel and had never been seen before prior to the initiation of the pandemic. The virus family actually was first discovered in the late 1920s. And this slide just gives you a listing of all of the different types of coronaviruses that we know of already. These first four, I won't go through the entire list, but these first four are the viruses that cause very mild symptoms, typically very similar to the common cold. And of course, the three viruses that we know that are more severe, the Middle Eastern Respiratory Syndrome, MERS-CoV, the severe acute respiratory syndrome, the SARS-CoV, which is the first SARS virus that was identified. The outbreak occurred in 2002. And of course, now the SARS-CoV-2, which is the virus that causes COVID-19. So how does the immune system actually fight infection? Well, here's a cartoon of a virus that infects a cell within our bodies. The virus gets into our cell and it begins to use the genetic code within the virus to make copies or pieces of itself. And these pieces will then assemble to make more viruses. And ultimately that infected cell will then be able to produce more viruses. That is really the life cycle of a virus. It gets into the cell, it makes more copies of itself, it releases more copies of itself to infect other cells. But in the process of doing that, it causes damage to our bodies. For our immune system, there are three types of cells that are very important. I'll refer to them here: the macrophage, the T cells, and the B cells. First cell to pay attention to is the macrophage. The macrophage is really very, very important because it's one of the very first cells that actually encounters anything that is foreign within our bodies. And it takes care of it by simply chewing it up literally into pieces. Macrophages will be able to identify viruses in our blood or anywhere in our tissues. It will engulf it. It will pull it into itself, and then it will begin to actually use enzymes that are within that cell to chew up the virus itself into pieces, and then it releases it out into your system. So these viral pieces that are released, those are the pieces that then actually get presented onto other cells in our immune system that are called antigen presenting cells. And this is how the immune system gets kick-started, because then this cell is now able to present the pieces of these viruses to our immune cells, which will activate other immune cells to then kill the cells that are infected with the viruses, or activate other cells that will begin to prepare antibodies that will go after that specific virus. And the antibodies are specifically targeting the pieces that are presented, which typically is oftentimes the spike protein of a virus or any other virus for that matter. That is in general how our immune system works. And the vaccine actually leverages on that whole process. Another unique thing about our immune system is that when we develop antibodies against viruses that we might be exposed to, eventually over time, our immune system actually develops some memory. And so what that means is if you were to ever become exposed to a virus again at some later date in life, then your body actually is able to remember seeing that virus before, and then it begins to make these antibodies again to fight off the infection. And that's what's referred to as the long-term immune response. And so for a vaccine, these are the features that we want to have available to us. We want a vaccine that will be able to allow the immune system to prepare itself in such a way that it can be prepared to fight off the virus, both whether it's initially at the time of infection, but also if there were to be future infections. Throughout this whole process, in any immune response to any viral infection, you're going to have symptoms. And I'm sure many of you will know that if you've had the flu, you've had these symptoms. You'll feel fatigue, you'll have a fever, or you may have muscle aches and pains. These are typical responses that our body has, which really does indicate that your immune system is literally kicking into gear to fight the infection. So what is the vaccine and how is the COVID-19 vaccine made? Well, this bar actually represents the genome, the genetic code of the COVID-19 virus or the coronavirus, SARS-CoV-2. And there are certain parts of the genome of this virus that codes for specific proteins that make up the entire virus itself. But the one thing we want to focus on is this burgundy piece of the genome, which is referred to as the spike protein. And actually, the COVID-19 vaccine only consists of this particular piece, the spike protein. What it is, it's actually the RNA sequence of the spike protein, which is actually this protein here, again, the COVID-19 virus. The spike protein sequence, this mRNA sequence, is then actually packaged into what we refer to as a lipid nanoparticle. What is a lipid nanoparticle? This is actually a tiny lipid droplet that is used to transport the messenger RNA sequence of the spike protein. It basically is a ball of fat, and on the inside is the mRNA, the genetic sequence for the spike protein. The liquid within the vaccine includes very benign substances like sucrose. And the reason why this nanoparticle is built this way is because all of our cells are, the lining of our cells is made up of lipids, fat. It is actually a fat layer that makes the outer layer of all cells. And so this nanoparticle, because it is a lipid nanoparticle, will be able to be targeted to our cells, and it will allow the vaccine to be able to merge with our cells so that the mRNA for the spike protein is able to go into the cells in order to initiate that whole process for the immune response. So this is what really happens when a person is vaccinated with the COVID-19 vaccine. That mRNA gets into the cells of our bodies, and the mRNA then codes for the spike protein alone, which is the antigen that then presents itself to the immune system. And that initiates the entire cascade where you have your immune cells becoming activated, and it begins to activate the development of antibodies that will be specific against the virus. And it will activate other cells that will be able to kill cells that are actually infected with the virus. So that is a way that we are able to arm our immune system against the COVID-19 virus. And of course, we anticipate that there will be long-term memory. Obviously, this vaccine has only been released recently. We do know that there's been some follow-up time where we've demonstrated that the antibody titers do exist. But obviously, for long-term, we will have to continue to follow folks to be able to confirm that this will be a lifelong immune response. But we don't anticipate that it would be anything other than that, based on the vaccine, the concept of the way that the vaccine initiates immunity. So what are some of the differences? I mentioned to you that the COVID-19 vaccine is actually an mRNA vaccine, and it's a little bit different from the conventional vaccines that we take routinely for other infections like the flu or any of the other vaccines for that matter. And there are some really very distinct differences. One is the production time. And I know a lot of people have often asked, why did it take them such a short time to prepare this type of vaccine? Well, here's one reason. The conventional vaccines that we have had over the years are typically made from viruses that are grown in chicken eggs or mammalian cells. It's a very complex process, and it requires the vaccine to be, the viruses to be grown in live cultures, and it takes a long time to do that. The mRNA vaccine, on the other hand, really just focuses on not the live culture of the vaccine, but just a piece of the genetic code, just a piece that encodes the spike protein. And because of that, that can be easily synthesized in the lab to generate multiple copies of the RNA sequence, which can then be used to batch to make the RNA vaccine. So one batch of the vaccine, an RNA vaccine, can take only up to a week versus months. One other difference between a conventional vaccine and an mRNA vaccine is this whole issue of biosafety. Conventional vaccines, because oftentimes they're made from large quantities of live virus that need to be grown, this obviously is a potential hazard. While the mRNA vaccine, on the other hand, is not live virus. It's not even the virus at all. Again, it is just the sequence that encodes the spike protein. And so there is no risk of infection. There is no risk of, the fact that you would have to grow up this COVID-19 vaccine. That does not happen at all. So there is a biosafety issue here that makes it very different. It also initiates the immune response slightly differently. In a conventional vaccine, what happens is that vaccine is usually a piece of a virus that is injected into the body. The immune system produces antibodies in preparation for the next time that you're exposed to the virus. On the other hand, the RNA vaccine is such that when the RNA vaccine is injected into the body, it enters the cells. And when it enters the cells begin to produce the pieces of the virus to present it to the immune system. And so the immune system is actually able to kick into gear right away. And if there is an infection at the time, it will take care of it. So that's one of the differences as well between the mRNA vaccine and a conventional vaccine. Another difference has to do with the flexibility of how it's made. The conventional vaccines really don't have much flexibility. It's a customized product, and the process is complex in terms of the purification and testing. And if there are any changes to the vaccine, you literally will have to start again. For an mRNA vaccine, because of the nature of how it is made, because it is a specific sequence that is being packaged, that encodes a piece of the virus, this type of vaccine actually is quite flexible, because as you have heard, one example that can be demonstrated in terms of the flexibility has to do with the emergence of these new variants. These new variants have slightly different sequences within different parts of the virus and in the spike protein. And so an mRNA vaccine actually has the ability to adapt to those changes, because you can simply just make adjustments to the sequence so that you can build a better vaccine to address any changes that may occur within if the virus were to mutate. And so it would be very easy for us to be able to make that adjustment to create perhaps a booster to address any variants that may emerge, perhaps that the original vaccine may not work against. So it really does allow for a lot of flexibility. As it is for all vaccines that are approved in the United States, all vaccines have to go through the same safety standards. There is a process. Before a vaccine is authorized, the FDA reviews all of the safety data from the clinical trials. And the data is also reviewed by the Advisory Committee on Immunization Practices. And this committee actually consists of independent body. It's an independent body from the FDA, and it consists of scientific and clinical experts. Those are the people that actually review the safety data and to make the decision or the recommendation for authorization. After authorization of a vaccine, the FDA and the CDC continues to monitor vaccine safety and side effects. And in particular, with regard to the COVID-19 vaccine, there is a monitoring system that the CDC has in place. It's called VSafe, where individuals who are vaccinated, if they sign up, you're able to actually report back how you're feeling each day. You typically get a text to your phone, and you literally have to answer some questions about whether or not you're having any signs or symptoms, how you're feeling that day. I think for the first month, you get a text every day, and then after that, once a week. So this is another way that the FDA and the CDC continues to collect data to monitor the whole process to ensure that everything is going well. And now I'm gonna just talk about some of the clinical trial, the efficacy trial results, so that you might be able to see some of the reasons why these vaccines have been approved for emergency authorization. This data that I will present is specifically referring to the Pfizer vaccine. This work was published in December of 2020. And there were over 40,000 persons who were involved in this clinical trial. At the time that this paper was published, the data here that I will present only includes 37,308 persons. And all of these people had been followed over a 2-month period. There were 2 groups of individuals. Over the 37,000 persons were randomized to either receive the vaccine itself or to receive a placebo. And what is a placebo? A placebo is simply nothing. It's saline. They were literally given salt water, basically injected. And so that's sort of the control to compare how well the vaccine response is among these individuals. So here's the data. This slide actually shows the local reactions for persons between ages 16 and 55. And just to kind of draw your attention to the color codes, it makes it easier for you to read the bar charts. So if the symptoms or the reactions are mild, it's green, moderate is blue, orange for severe, and 4 for grade 4, which is the most severe reaction. And these are the reactions, the local reactions at the site of injection that was reported by individuals. This first bar refers to the persons who received the vaccine. And of course, the second refers to the persons who received the placebo, which is the salt water liquid. There was pain that was observed at the injection site. And as you can see, most persons who received the vaccine, both dose 1 and dose 2, had some pain at the injection site. And then they also monitored for redness or swelling at the injection site. And of course, as you can see, 5% of the individuals who got the vaccine after dose 1 had redness, and 6% had redness after dose 2. Only 1% with the placebo got redness at dose 1 and 2. And again, swelling, no one who received the placebo got any swelling at the site, but persons who received the vaccine, 6% had swelling at dose 1 and 6% at dose 2. So for the most part, the majority of the local reactions was really pain at the injection site. And this pain was reported to only last for a couple of days. After a couple of days, then the pain went away. For persons over the age of 55, again, similar picture. Majority of the individuals who received the vaccine only had pain at the injection site, and there were very few persons who had any redness or swelling. Now let's look at the systemic reactions, and this involves fever, fatigue, headaches, chills, vomiting, diarrhea, muscle pain, joint pain, and also whether or not persons had to take an antipyretic. An antipyretic is simply a fever-reducing agent for Tylenol or ibuprofen to reduce the fever. The same color code is as is from the previous slide. The green refers to mild reactions, the blue refers to moderate reactions, the orange is severe, and the red is grade 4, which is the most severe. As you can see from the bar charts, the majority of persons from ages 16 to 65 had systemic reactions that involved fatigue, mostly, as you can see for both dose 1 and dose 2, and headaches. Some persons, 52% got headaches after dose 2, 42% had headaches. But of course, after dose 1, 42% had with the vaccine had headaches, but 34% with the placebo also had headaches. So we need to take that into account as well. There were also a lower proportion of persons who had chills, 35% after dose 2, only 14% after dose 1. And then of course, very few persons, 1 to 2% had vomiting, 10% had diarrhea, 8% with the placebo, and 10% with the vaccine, which is not a very significant difference between the two. Muscle pain was another observation that was reported, where after dose 2, 37% of the individuals with the vaccine reported some muscle pain, but only 8% with the placebo reported muscle pain. And then there were also some people that reported joint pain. And as you can see, there were more people who actually took, whether it's Tylenol or ibuprofen to reduce their fever. More of those persons who received the vaccine took those medications compared to the placebo. A similar picture is observed for persons over the age of 55. Again, the most commonly reported systemic reactions were fatigue after dose 2, some persons also after dose 1, headaches, chills, muscle pain, and then of course, some joint pain. Again, all of these systemic reactions actually only occurred within about 2 to 7, they resolved within 2 to 7 days after the dose was administered. So it was not chronic or long-term. So I think this is the most important slide, which really talks about the efficacy. How effective is the vaccine? All right, so let me walk you through. This column refers to the persons who received the vaccine. This column refers to the persons who did not receive the vaccine. This is the placebo. There were over 18,000 persons that were vaccinated, and these individuals did not have any evidence, prior evidence of COVID-19. And of those persons, only 8 of the 18,000 reported to have COVID-19 at least 7 days after their second dose. In contrast, a similar number, 18,325 persons received the placebo. 162 of those persons were reported to have had COVID-19 at least 7 days after the second dose. This results in a vaccine efficacy of 95%, okay? Similarly, this second row actually refers to another set of persons, over 19,000 individuals that received the vaccine. All of these people had no evidence of COVID-19 prior to injection, and some also had some evidence of COVID-19, evidence of infection, I'm sorry. So this includes persons with and without infection that were vaccinated. Of the 19,965 persons, only 9 cases actually developed COVID-19 at least 7 days after the second dose. And of the 20,172 persons who got the placebo, these are persons with and without evidence of infection. 169 of these persons developed COVID-19 after 7 days after the second dose. And again, this was an efficacy of 94.6%. So what this told us is that the COVID-19 vaccine does work to prevent COVID-19, the disease. And the data actually shows that getting vaccinated will prevent someone from getting sick with COVID-19. The data also shows that people who have already gotten sick with COVID-19 may still benefit from getting the vaccine. There were persons who had had evidence of infection who were vaccinated in the trial, and the efficacy was still just as good, over 90%. The COVID-19 vaccine cannot give you COVID-19 because, as I indicated, it is an mRNA vaccine, and it's the mRNA sequence of just one piece of the virus, one piece which encodes the spike protein. That is not able to provide to generate any sort of illness really that is attributed to COVID-19. And a lot of people do ask this question, whether or not the COVID-19 vaccine will cause you to test positive for COVID-19. And that is not the case. You cannot test positive for COVID-19 if you've been vaccinated, because you have not been infected by the virus. You are simply just expressing the spike protein, which is just a piece of the virus. And so you would not be expected to be positive for coronavirus if you were tested. For persons who do choose to be vaccinated, most importantly, we still need to keep in mind that there are some preventative measures that we have to continue to keep in place. We have to continue to cover our nose, mouth with a mask. We have to continue to social distance as well, avoid crowds and poorly ventilated spaces. And of course, wash your hands and clean and disinfect frequently touched areas. The reason for this is that the vaccine data shows that it is efficacious. The efficacy that was presented by these trials shows that the vaccine is effective in preventing COVID-19, the disease. What we don't have yet is enough data to show whether or not it prevents us from being infected by the virus. It will require us to continue to collect data over time. So eventually, once we continue to collect data over time, we will be able to answer that question. And that is the reason why the recommendation is in place that if you are vaccinated, you are protected from getting COVID-19. But we do not yet know whether or not the vaccine prevents infection from the virus itself. And so in order to protect the other persons that are around us, we need to continue to maintain the precautionary measures that we have in place. And of course, the recommendation is as well to enroll in the VSafe, which is the CDC monitoring program, because that also helps to provide additional data to the CDC as they continue to collect data in order to better understand more and more all of what is happening with the vaccinated groups, so that we can be best able to make appropriate recommendations as time goes on. The more we know, the more we can react in order to ensure that we remain healthy. The last slide is I would encourage you to really make sure that you are getting your information from credible sources. And I strongly recommend that if you are interested in getting more information about the vaccine, go to the CDC website. There are other websites out there, but definitely the CDC is one of them, one of the websites that we know that has credible information. And so that is so important to make sure that you do pay attention to the source of information, where you're getting your information from, because you want to be sure that you are getting correct information and not myths. And we know that there are lots of myths that are out there. So thank you very much for your attention.
Thank you so much, Dr. Reagan. You have quite a bit of questions. And I believe you did a great presentation. I thought that the vaccine was made of from the killed virus itself, but I'm now noticing that it is just a little small part of the virus that makes up the vaccine. One of the questions that was asked is, can it change your DNA? Can the vaccine change your DNA?
No, the vaccine cannot change your DNA.
Another question, can you still get the virus after you have been vaccinated?
So it is possible, and that's what I mentioned to you about why once you've been vaccinated, you should still continue to wear your mask and social distance, because we do not yet have enough data to confirm whether or not you will not be infected after you've been vaccinated. It will take us some time to continue to collect that data in order to confirm whether or not that's the case.
So we're not sure how long of an antibody buildup, like say 2 weeks, after the second shot, you should at least be somewhat better. There's still no data on that.
The data does demonstrate that actually after the first shot, 10 days after the first shot, you begin to have a titer. You will have antibodies. And then once you get your second dose, at least up to 2 weeks after that, you should be at the high enough titer that will give you that, that effective protection against COVID-19. So definitely we do know that. And we do know that the titer does continue because, as I said, the trial followed persons for at least 2 months and individuals still had their titers maintained. As we go out, as time goes by, we will continue to follow. All of these persons who've been vaccinated in these trials are still being followed over time. And so we are continuing to collect the data over time, and that will let us know how much long-term we anticipate that the antibody titers will be. We expect it will be long-term, but we can't say that obviously until we have the data. We have to look at the data.
Right, because this is science.
Right.
Gotcha. The virus, if you've had the virus and you have some level of antibodies, do you really need the vaccine? I know you mentioned that it does benefit, but somebody is like, well, if I've already had the virus, so I should have some level of antibodies, what's the point of getting the vaccine?
Well, actually, the data actually shows that the titer that you get when you are vaccinated is way higher than the titer that an individual has if they got the infection. So you get more protection with the vaccine on top of what it would have been if you were just infected and you had your own antibodies.
Okay. The next question says, if it is effective on the mutant variations. Now, I know you mentioned earlier that because it is an mRNA virus, that you're able to adjust the vaccine a whole lot better than traditional measures of vaccinations. So we might need a booster. So does that mean that we're good for the regular COVID, but for the mutant strains, we might need a booster in the future? Or
so we know that obviously. Yeah, I'm sorry. Yes, so we know that obviously as the strains, the mutant strains that we refer to, as they emerged, everyone kicked into gear. The scientists have already kicked into gear to try to investigate whether or not the vaccine that currently is released, whether it is effective in neutralizing these strains. We do know that the Pfizer has already done some experiments and have shown that when they use the neutralizing, the anti-sera, the antibodies from persons who were vaccinated, it does actually neutralize the strain from South Africa, as well as I think the UK strain. So at this moment, we are confident that the current vaccine will be able to neutralize these strains. But of course, we have to continue to monitor things. And, if it does change, then we have the flexibility to make that change quickly.
Okay. What are the risks for someone with cardiac and kidney disease? And that is to get the vaccine. I know that the virus really attacks kidneys, lungs, and heart. So if you already have those issues, what are the risks should you get the vaccine?
Well, what I will say is, looking at the vaccine data, the individuals that were included in the trials, I did not mention this, but it was a combination of healthy individuals, but also individuals who had chronic conditions, not excluding HIV. So I would probably have to look at the details to see if persons with kidney disease were included in the trials. I don't know off the top of my head. What I would recommend is talk to your doctor about it if you do have some concerns about that, and try to get as much information about the trials, going to credible sources to really inform, to allow yourself to make that informed decision.
Will it affect your autoimmune system?
Well, the vaccine actually promotes your immune system to actually react and work in the way that it should. Persons who have are you referring to persons who have autoimmune disease? Is that
I'm assuming this is a question that I have in the chat. I'm assuming that that's what it is. That maybe if you have an autoimmune issue, will it mess with your autoimmune system?
So it would be hard for me to really give you an answer to that. I have to look at what the data tells me. I do know that there are persons in the trial who have had chronic conditions, and some of those persons did have autoimmune disease or immune compromised individuals as well who are part of these trials. And obviously the data shows that it was effective. But again, I would say with these types of concerns, have your discussion with your doctor if you do have a concern, and try to get credible information in order to make the right decision.
Okay, the person just texted that, yes, they were referring to someone with autoimmune issues. What in the vaccine can possibly cause death? And I know that as a nurse, we tell everybody, no matter what we give you, whatever medication, anything can possibly cause, because we don't know what is in your system or what comorbidities you might possibly have. But is there anything specific that you might say, oh, you better watch out for? Anything that you would say?
Well, I will say this, for any trial, whether it's the COVID vaccine or any vaccine to begin with, the first thing that they look at is safety. Before you even look at efficacy, safety is the key. And so all of these things have been evaluated for these vaccines, and you have seen the data, at least, well, from what I've shown you, the response to the vaccine involves local or systemic response. Okay. For me, I cannot say that there is something that you need to look out for that's going to cause death, because there is no indication that there is anything in the vaccine that is harmful. Again, it's a lipid molecule that has mRNA, and the liquid within it that in which the mRNA is swimming in is sucrose. Sucrose is sugar.
Okay, we have two more questions. Will the vaccine help to fix any damages done? So we know that COVID-19 causes lung issues, heart issues, etc. If we get the vaccine, will it then help to fix anything by any chance? That's another question.
Right. No. The vaccine, the main job that the vaccine has is to promote an immune response against the virus, against the spike protein. That is what the vaccine does. It doesn't fix anything.
Figured. If the virus is contracted, will the vaccine fight the infection?
Yes. Yes, it will. And that's one of the really good things about the mRNA vaccine, because once the mRNA is administered and your cells begin to make the spike protein, your immune system then recognizes it and kicks into gear. So if there's an infection at the same time, your immune system is now being armed to be able to fight the infection.
Awesome. We have one more question from Pastor Heron. Go ahead, Pastor Heron.
I think he got disconnected.
Okay, well, when he comes back, we'll allow him to ask that question. Thank you so much, Dr. Reagan. That was awesome information. We are so thankful for your knowledge. Our third and final speaker today is going to give us information on COVID-19 community disparities related to who is affected by the disease, meaning giving us statistics, and vaccine administration statistics. And our third speaker is none other than Dr. Folakemi T. Adedina. So Dr. Folakemi Odedina is professor in the colleges of pharmacy and medicine at the University of Florida. She is also the contact principal investigator and program director of the Florida, California CARE Health Equity Center, a US NIH National Cancer Institute, $16 million center. Wow. She is the PI and founder of the NCI-supported Prostate Cancer Transatlantic Consortium, the research core director for the Florida Health Equity Research Institute, and the chair of the research committee for the African Organization for Research and Training in Cancer. Recently, she was elected to serve as a council member of the American Association for Cancer Research, Minority in Cancer Research. Her research program, primarily funded by the US NCI and Department of Defense, focuses on developing cost-effective, community-based behavioral trials to address health disparities globally. She has directed over 30 research projects, including the NIH Community Engagement Alliance Against COVID-19 Disparities Program. Please welcome Dr. Odedina at this time.
Thank you so much for that very, very warm introduction. And I really want to thank the Church of God for inviting me. I want to thank my dear friend, Dr. Camille Reagan, for extending the invitation for me to speak today. And first, I wanted to say thank you so much that I came into the Zoom presentation and it was a praise worship. For anybody that knows me, I am the queen of praise worship. I wake up praise worship, going to bed praise worship, exercising praise worship. So thank God for his move. This is a move. Thank you so much. What a great presentation by Dr. Roland and Dr. Camille Reagan. And I wanted to also say to Dr. Reagan that thank you for the two of you choosing very nice topics, and I have to be the bearer of bad news. Talking about the disparities and talking about how it affects us, but hopefully I hope I can end my presentation by talking about what do we need to do and what does faith-based organizations like the Church of God really need to do for us to be able to fight, for us to be able to fight this. But I want to follow up on one of the questions that Dr. Camille Reagan asked, and that's to say that there are currently, and I think about 1,000, over 1,100 deaths that have been linked to the vaccine. So the thing is that for people who have a lot of coexisting morbidities, you really have to work with your physicians. And I think that is very important, that you work with your physicians to make sure that it's okay for you to take this vaccine, because as you know, and as Dr. Reagan outstandingly presented, research is still ongoing because this is we know so little about what is going on. So it is very important. So I've been asked to talk about COVID-19 and vaccination disparities. So I've sort of divided my talk into three. I'm going to talk about, first of all, COVID-19 disparities. And welcome to the state of Florida. I think we get, the state of Florida is one of those states that is not really doing too great when we talk about disparities and the vaccination. But much more importantly, I really want to talk about what do faith-based organizations like your church really need to do to be able to be in the forefront of fighting disparities within our community. So that's kind of what I'm at. I want to start with, there have been things that have been in the newspaper that are correctly summarizing what is going on. So there's this news in Miami Herald by Ben Konak and Douglas Hanks, and you may have seen it, that talks about why a Miami-Dade Broward vaccinating Black residents at slower rate than white residents. This is what is going on in the state of Florida. And another one talks about, by CBS News, talk about the fact that Black and poor people are really left behind in the rollout of the COVID-19 vaccine, which is really, which is a huge problem. I happen to be part of a coalition that is funded by the National Institutes of Health that comprises 11 states, and the state of Florida is one of those states. And the funding that we have in the state of Florida really focuses on us really addressing COVID-19 within communities of color, including the Black and Latinx communities. And for us to understand, why do we have these disparities? Why do we have the issues of vaccine hesitancy in our community? What does our community feel about participating in clinical trials, and how can we do better to make sure that we are able to really fight this deadly infections within our community. So first of all, I want to talk about COVID-19 disparities. So when you look at this, graph, you can actually see from the map of the United States, and I think Dr. Rule presented this very well in his presentation. You can see from the map where the DACA area is actually where you have a lot of incidences of COVID-19. And so that is some of the things that we need to sort of, oh, my slides are not advancing. Can you see my slides advancing? Oh, resume, okay, let me go.
Oh, now I see it.
Okay.
It wasn't showing earlier.
Yeah, I don't know what is going on. Okay, here we go. Let's start again.
There you go.
Okay. Okay.
Yes.
Can you see
Now
the,
we see it. Yes.
okay, great. So I want to talk about who is affected. And I think Dr. Rule did a fantastic job of really covering the state. But if you look at the map of the United States, the DACA it is, you can see that's where you have a whole lot of where you have COVID-19, and you can see where we are in the state of Florida. But when you look at deaths nationally, it's not only in the state of Florida. Just look at the deaths per 100,000. And you can see, unfortunately, as Blacks, we are leading. That's just the unfortunate part of it. Dr. Reagan and I, we study cancer disparities, and it's kind of huge within our community. And here we are again with COVID-19, and you look at mortality, and as Black, we are leading in COVID-19 mortality. This one is really something that I want to just clearly for you to look at this map. This talks about the age-adjusted COVID-19 deaths as compared to the population that you have. So the red bar is actually talking about the distributions of COVID-19 deaths, and the blue bar is talking about the distribution of our population, where we are. So let's look at the population of whites, and you can see the population of non-Hispanic whites. They are just like about 59% of the population. And then you can see how they are, the blue bars, they are about 59% of the population in the United States. And then you can see where they are with respect to COVID-19. So they're kind of like about 30%. So the death rate within the population really is not as high as their population. Now look at the Hispanic population. Right, the Hispanic population is about 20%, but the death rate for COVID-19 is like about 38% of it's much more higher than their representation of their population. The same for non-Hispanic Black. We are only about 13 to 15% of the population, but we are like comprising over 20% of the death rate. So this is like staggering. How can we be much more than our representation in the population? This kind of shows that this is a huge problem that we have. So going on again, this specifically now talks about the hospitalization rates. Who is being hospitalized? And you can see the Hispanic population, the American Indian or Alaska Native, and the non-Hispanic Blacks. They are the ones that are disproportionately affected by this disease and being hospitalized more, as compared to non-Hispanic Asian and compared to non-Hispanic white. Specifically for Florida, you can see the deaths by race. The death by rates for whites is 96 for Black is 121 per 100,000. When you look at it for ethnicity, the non-Hispanic are actually doing better. We are doing worse, 128, and then the Hispanic are doing a little bit better. So it summarizes that it appears as if the non-Hispanic Blacks are the ones that are significantly being affected by this disease. Now, let's talk a little bit about vaccination. So now you know that we are disproportionately affected. We die more from COVID-19. We really, are more hospitalized from COVID-19. So let's kind of talk about the hospitalization of vaccinations. And before I talk about the vaccination, I think I want to drive home one of the things that Dr. Reagan said, and that is the fact that really, and I think Dr. Rule also made this point, we have to make getting the vaccine a priority for us. One of the things that we studied with the NIH study was looking at, acceptance of vaccine within our community. Our communities, for several reasons that are well justified, do not want to accept the vaccine. A majority of the things that we found from doing our study in Florida included the fact that people talk about the history of Tuskegee, the history of not, treating Blacks and Latinx very well with clinical trials, the disinformation, the misinformation, the politics that is surrounding the COVID-19 and the vaccination. Thank God Trump is no longer there. But all those things, and the fact that there's limited access, the fact that we are more likely to have comorbidities, and the fact that the representation of our community in the vaccine trials is about 10% for Blacks, right? So we actually have the lowest, is about 10% representation. These are the things that our population, the Black population told us in the study that we did that this is the reason that we don't want to do it. In fact, for the study that we did, we sort of, we had like focus group with over 50 people. Only one Black woman actually said, I think I'm going to get it. Everybody, and the funny thing is that everybody said no. She was there with her husband, and her husband was trying to convince her to say, no, don't think about getting it as part of it. So this is really something that is very paramount, really something that I think as a faith-based organization, we need to deal with it. And we need to say that we need to get vaccinated. We need to, for several reasons. The vaccine is the thing that is standing between protecting us, protecting our loved ones, and protecting our community. That's it right now. That's it. And if we don't get vaccinated, it's going to be a huge problem for our community. So I want to sort of hold on before I talk about the disparities with vaccination, just kind of tell you a little bit, just emphasizing what Dr. Reagan has talked about. If you hear nothing about what I talked about today, I want you to hear three things. Number one, trust the data. Trust the data, trust the science. That's number one. The people who, like myself, like Dr. Rule, like Dr. Reagan, who are working in this particular area, we make sure that the science is objective. It's objective because that is sort of what we devote our life to. So we cannot lie to you. That's number one. So please trust the data, trust the science. Number two, trust the Black scientists and clinicians who have spent their life in making sure that they address disparities in our communities. I've been working in the area of health disparities for over 25 years. And so for me, it is something that I'm very familiar with, and I think it's very important. And then lastly, trust the FDA. Trust the FDA. The FDA is really one of the most rigorous agencies in the world. And I have a global program, so I deal with a whole lot of regulatory agencies all over the world. And in trusting the the FDA, I want to emphasize the journey of vaccine, and this is why you should trust it, right? This is why you should trust it. There are 4 phases before a vaccine can come into the market. And these phases, there has been no cutting of corners with the COVID-19 vaccine, no cutting of corners. Phase 1, answer the question, is it safe? Does it have any serious side effects? How does the vaccine dose relate to any side effect? Is the vaccine causing an immune response? Okay, this phase was completed. So, for example, before Moderna and Pfizer went to the second phase, phase 1 was completely done, right? Then they do phase 2. And then they're going to ask the questions, what are the short-term side effects of the vaccine? What is the body's immune response to the vaccine? Are there any signs that the vaccine is really protecting people? Okay, once they do phase 2, then they go to phase 3. And phase 3 is when they're asking the questions, how do disease rates compare between people who get the vaccine and those who do not get the vaccine? And that's what Dr. Reagan was talking about. Like when you have the placebo and you compare it to the people who get it. Is it effective? Do you see a difference? How well can the vaccine protect the people from the disease? Are there long-term or rare side effects? So once they finish the phase 3, then they have this big report that they take to the FDA, and the FDA goes through reviewing to ask, is it safe and effective? Does the benefit outweigh the risk? And that is the only reason the FDA granted the approval to these 2 vaccines that are out there. Very important. And just to emphasize, Dr. Reagan also talked about the last phase, which is phase 4. Now that phase is when we are now using it. For example, I've gotten my 2 doses of the Pfizer vaccine, and now it is being monitored to make sure that there's, are there safety issues? Are there any compromises? Are there anything? And from phase 4 is now when FDA is learning that there have been over 1,000 deaths that is associated with the vaccines. And that is the knowledge that these deaths are occurring in people that really have a whole lot of comorbid conditions. So the issue then becomes, how do we figure out what comorbid conditions really are the ones that we need to watch out for, or the people need to not take the vaccine? Okay, so I just want to kind of put that out there, that please trust the vaccine. With respect to the COVID-19 vaccine administration, this is the map of United States that shows you where is the vaccination being taking place. And you can see Florida, we are not doing that well, right? We have DeSantis. What am I going to say? One, that's all you have to say, right? This is, you just kind of look at this. I've given you the statistics for the state of Florida and for United States. For the number that received the first dose, the percent, so there's about 10% of the population that has received the first dose in Florida. And there's about 4% that have received the second dose in Florida. So I'm part of the 4 dose, for the people who have received the second dose. I've done dose 1 and I've done dose 2, right? And the distribution per 100,000, you can see is 279, as opposed to 730 nationally. We are not doing well in Florida. Overall, within the state of Florida, we are not doing well. But then when you kind of look at, so when you kind of look at the summary from different counties, and I believe this is looking at Broward County, you can see how many people are getting it based on whether you are white or whether you are black. The low number is so low for our community, right? Very low. And the next one is actually Miami-Dade. Still low. This is very, very low number. When you compare the people that are white and when you compare the people that are black. Now, I want to go back to what has been reported that I showed earlier on. One of the things that bothers me about what is being reported is the fact that DeSantis, our governor, has really given, at the beginning, gave the sole distribution primarily to Publix. And I love Publix and I shop in Publix and it's great. But to find out that majority of the places where you have Black population and Latinx population don't even have Publix, right? And it took a lot of people within the community to do a cry and say, what are you doing? You know, it's only Publix that is doing it. The people in the Black communities, they are not being vaccinated because Publix is not in their community. Now, it's now adding Walmart and it's now adding Winn-Dixie. So those are things that, this is one of the reasons why advocacy is so important. We have to keep an eye on what the government is doing and how they're getting this. Now, I'm going to stop on this, and I just wanted to kind of take a look at this. This is the graph that concerns me the most. This graph really concerns me. This is for the state of Florida. It is race and ethnicity as a share of COVID-19 vaccinations. What I've provided is the percentage of people vaccinated, the percentage of cases that we have, the percentage of deaths, and the percentage of population. I'm going to start with the Black. Actually, no, I'm going to start with white. Okay. The percentage of total population of the white folks in Florida is 75%. The percentage of people, of whites who are dying from COVID is 55%. The percentage of cases is 40%. Now look at the percentage of vaccination. It's 76%. It's greater than the percentage of population. It's greater than the percentage of deaths. It's greater than the percentage of cases. Now let's switch to Black. We are 16% of the total population. 16% dying from it. Equal number of our population is dying from it. It's not reduced. About equal number of our population is getting the cases. Now look at the percentage of vaccinations, 6%. I mean, I just want to flip my top because it does not even make sense. This does not even make sense. Look at the bar, just look at the bar. The blue bar is the percentage of people who are getting vaccinated. Look at Black, look at Hispanic, look at white. And this is systemic. It's systemic in the sense that the access is being provided in places that whites can get it, right? But another part that, and so we need to do a lot of advocacy to get the vaccines where they need to be. But another part that I think your church really needs to be part of, and I'm going to talk about it in a few minutes, is the fact that we also need to educate our community. The vaccine hesitancy and the issue of our community saying we don't want to take the vaccine, we don't trust the vaccine, we just got to stop. We got to stop because just look at the numbers. It's not working for us. These numbers are not working for us. So we really need to, on an individual level, on a personal level, we need to figure out a way to accept, to be able to accept it. So having shown that graph, I don't want to leave us with being depressed. I want to talk about what can you do? And so I want to talk about what can the church do? What can faith-based organization do? Which I think is the most important thing that we need to think about. So first of all, I want to talk about using CDC's guidance. Please, as a church, we should not be looking at those WhatsApp messages, looking at those Facebook messages. It is so amazing the amount of misinformation and disinformation that are out there, and it's killing our community. So as a faith-based organization, we should look, the CDC website has a whole lot of very helpful. If you want us to break it for you, please contact us. We have a seal program. We will send you whatever materials that you need from CDC and from NIH. Okay, so let's use CDC guidelines. Let's make sure that we are using safe ways to connect with community members and share COVID-19 prevention information with them. I know that as Black community, we love the in-person thing, we love the feeling, touching thing, but no. I mean, if we want to continue to do that, the church needs to be leading in saying we need safe ways to connect with each other. And because I care for your soul and I also care for you, we are going to do this in safe ways. Phone calls, Zoom meetings, social media, we can use a whole lot of ways. I mean, we are communicating right now, like through Zoom. So the church needs to be ahead and making sure that is something that we want to do. Please partner with the local media. It is amazing how much the local media really wants to partner with faith-based organizations to be able to get any messages that you have had. If you are doing workshops like this, we are holding panels like this, they want to actually know so that they can get the word out for you, right? Newspapers, radio, TV, they want to partner with you. Please familiarize yourself with and partner with healthcare providers and resources within your communities. There's a lot they are looking for. So for example, University of Florida is partnering with churches in our Alachua County to go and give the vaccines there because they know churches can draw crowds, right? So to getting the right screening done, to getting the right treatment, to getting vaccination, you can partner with them. You can just reach out. They will love to partner with you because they are looking for ways to be able to reach our community, right? So also, work with other partners to connect people. I was so glad that Dr. Rule, really has expertise in the area of mental health. One of the number one thing that we found when we did a study with Black communities is the issue of mental health. Because our community is the kind of community that likes to socialize, the church is something that people look forward to on Wednesdays and Sundays. And sometimes it's the only avenue for socializing and for being out for many people. And that being gone, it is really affecting mental health. It's coming on top for us away and away. So please, connect with resources and services to meet the physical, spiritual, and mental health needs of your community. And I also want to say, partner with academic health centers or research institutions. It's very important that we work, in the area of research, in the area of disseminating research findings that we found in recruiting for clinical trials. I think faith-based organizations really have they are kind of like the pillar of being able to work with us. I want to end by just kind of introducing you to the NIH program, which is called the Community Engagement Alliance Against COVID-19 Disparities. It's called the SEAL program. And like I said, the state of Florida is one of the funded SEAL programs. There are multiple organizations and institutions that are part of this Florida SEAL program. University of Florida is part of it. And what we want to do is make available the most accurate information. We have a lot of resources. So I know Dr. Reagan knows this. So Dr. Reagan can put you in touch with my program manager. Her name is Jessica Otero. She is fantastic. She's actually the one that represents the Florida SEAL for health communications nationally. So she's the first person that gets anything that is coming from NIH. And she's also connected with the office of Dr. Fauci because she's representing us with health communication. So reach out to her, she will get you whatever we need. We want to be able to increase the use of preventive services. We want to be able to increase the public's understanding of how science works. So we are here to partner with you. We'd love to partner with you. We will give you whatever resources that you need. I just want to end with this. COVID-19 does not discriminate. So it is really great that we are part of the National SEAL program. So whatever you need, whether it's from Fauci's office, whether it's from the NIH, whether it's from CDC, we can really get it for you. Thank you so much for for inviting me, and it's really a pleasure to be here.
Thank you so much, Dr. Odedina. We really appreciate your knowledge on this subject. I will say with regards to the Black community that when we first heard of the vaccine, number one, we kept hearing that we didn't know what this virus was about, what it could do, and how to even fix things. And then by the time we blinked, there was this very quick vaccine that was prepared. I'm thankful that Dr. Reagan actually touched on that it's not prepared as the traditional vaccination doses. And so therefore it was able to be prepared at a faster rate. And then you bringing in the phases that it goes through as to whether or not it is safe, and if it was safe for humans and etc., that phase piece that you put in made it a little bit more reassuring that they didn't just kind of come up really quick with this and then threw it on us. The other thing I will say about the Black community is that because we always are what we would tend to say the guinea pigs when it comes to certain vaccines, and the fact that there are disparities is why whenever something new comes up, there's always a pushback until we can feel some level of comfort. And I think because, again, the vaccine has come out fast, there's the science, we are seeing the science actually work out, because we know, okay, the vaccine is working, but until we get that data out, it's like there's not a comfort level. So a lot of times there is a delay in actually responding to the vaccination, the call for being vaccinated. So I'm thankful for the information that has gone forth. We do have quite a bit of questions in the chat. And is the COVID-19 virus man-made?
No, I mean, no, yeah. Camille, no.
And anybody can answer that.
No.
No, it is not man-made.
Oh, okay. Is the coronavirus the same type of presentation that shows death by zip code, the way the AIDS virus did? So you knew that in certain populations or in certain areas, you could tell that when it was the AIDS virus, this particular population or area code, was expiring at a faster rate. Could you say the same about the coronavirus?
I actually think the AIDS virus picture is a little bit different from the coronavirus, but there are a little bit of similarities immediately when you see the AIDS virus moving. The similarities with disparities is the fact that the same problem, this is why we have disparities. Disparities are typically based on social determinants of health, right? And because of issues of social determinants of health, they are like, where we live, the air that we breathe, the environmental factors that we have, access to healthcare, access to screening services, the issue of discrimination in the healthcare system, those same things have not been addressed. And so because those same things have not been addressed, the Black, Latinx, and Native American, they are always going to have this issue of disparities. And that is the problem that we are facing. I gave you an example. Our governor in Florida started, let's distribute the vaccine en masse through Publix. Okay, well, Publix typically is not always in the Black, neighborhoods or Latinx neighborhoods. So when you say, the vaccine is there for you, go to Publix, well, I'm not in Publix. And then another thing that we are finding out and is now being pushed back is the fact that when you look at counties that are predominantly white, there are more access to vaccinations compared to counties that are predominantly Black. So those issues of social determinants of health, those issues of healthcare access, we haven't conquered them. So anytime that you have another disease or infectious disease, you're going to see similar pattern. And I know that is why majority of our populations are really tired. I mean, they're tired of hearing, cancer is more in us, diabetes is more in us, cardiovascular is more in us, and now COVID-19 is more in us. But it is because the fundamental problems are about the same, unfortunately.
And I'd also add to Dr. Odedina, right? So you're right in terms of the structural problems in terms of healthcare and the access.
Yeah.
Part of the issue with the vaccines, though, is so you have a lot of larger pharmacies that are not in Black communities, right? So even when they roll it out, for at least where I am, you have persons who have to call in and who have to actually register online to do their vaccines. A lot of us have issues with IT connectivity or even just the facility with using that piece. So if that's the bulk of how you help people to get an appointment for vaccination, to be registered, that's another barrier that's presented for our communities as well.
Yeah.
I mean, you can call, but really it's easier for us to go online and do that. That's also a problem.
Which is not easy. I'm going to tell you. I'm glad you brought that up, Dr. Rule, and Dr. Reagan also knows. We get calls from at our center with people who want us to help them register to take the vaccine. And there was a time that we had my research program, and my research program staff, they were showing me going online to the Department of Health website and how difficult it is. You can't even find the link. The link is buried somewhere, right? That you can never, my staff, it took them a while to find the link, and then they were helping other people to register. And then a couple of days later, the link was broken and they stopped calling people, and then you call the number. So it's just, it's like so many, things are being pushed at people and so many barriers, and it's not really easy. And you're quite right. This is one of the things that I am really proud of what Biden is doing. Now, the way Biden is rolling out some of these things. So for example, my colleague at Florida A&M University just texted me yesterday and said, do you realize that Biden has made it that Florida A&M University is now one of the sites to give vaccinations? You think about it. Florida A&M University is right there in the Black community, right? And so it makes it easier for them to be able to do it. So Biden's administration is being purposeful in saying, let's go with the HBCUs. You have to give vaccines where the HBCUs. You have to give vaccines in the independent pharmacies that are minority owned, because they typically they are a minority. So, so this is where it's so important to have representation, because I'm sure the HBCU thing most probably came from Kamala Harris, because she's a graduate of HBCU, right? Institution. So yeah, you're quite right. It's very frustrating even for us. And I have very capable staff who knows what they're doing, but it's still frustrating.
Okay, a few more. And I kind of know the answer to this. Is there a way to eliminate the root cause of COVID-19? And if there's not a way to eliminate the root cause of COVID-19, then is the vaccine really the answer?
Yeah, the others can also jump in, but I'm going to tell you the vaccine is the answer right now. The vaccine is the answer. In addition to social distancing, masking, now they are saying double mask, to be honest with you, because so social distancing, masking, if you don't have to go out, don't go out. That's what I do. Unless I have to go out, I don't go out. I double mask when I go out, although I'm vaccinated. I still double mask. I wear gloves. I know people laugh at me. I don't care. I wear gloves into the store. When I come out, I take off my scarf. It does not matter that they have wipes. I don't care. Whatever the bottle I'm carrying, the grocery I'm getting, I don't know who has touched them. So I double mask. I wear gloves. I get wipes. I wipe everything down, and then I toss away my glove. But I understand that if you have comorbidities, please, as Dr. Reagan said, please work with your healthcare provider. They really need to figure out whether you can. But but if they figure it out and they say yes, and I know our communities, I understand. We've done the study, And I'm going to tell you the truth. My first daughter, who is an occupational therapist, master's in occupational therapy, it took me to tell her that, you know, over several days that you need to go and get the vaccine. And what I told her was, I said, I don't really care about you right now. I care about my 2 grandchildren. So you need to go and get those vaccines because you need to protect my grandchildren, right?
So in a nutshell, there is not a way to eliminate the root cause. It's a virus, but the vaccination is the answer from the standpoint of it will then give you some level of antibodies to then reject the virus.
Similar to the flu vaccine.
Yes.
Yeah, go ahead.
So similar to the flu vaccine.
Yeah.
Which good. So we do get some level of an antibody. So the key to that is to eliminate the root cause of COVID-19 is the vaccination, which will help you to build up. And as we continue to get data, while we're in the pandemic, we have the vaccine, but we still do the social distancing, the hand washing, and the mask wearing.
Mm-hmm.
Yes,
Right.
and I just
Go ahead.
one last to add to that. I think we really need to understand the reality of things. The COVID-19 virus is here. It's not going anywhere, and the only way that it will continue to stay alive and continue to infect people is if there are people to infect. Which means if you do not have the immunity to fight the infection, to prevent the disease, to prevent the perpetuation of the infection or spreading it to others, then it will continue. It will.
Similar to smallpox and everything else, those vaccines, those issues, polio and all of that we eradicated in years past.
Exactly. It's the same scenario. Vaccination, we know this. We've done this for other infections, for polio and smallpox. It's the same scenario.
The only thing I would like to add to that is that the only place that we can have a new normal, it's not normal, a new normal, it's when close to 75% or 80% of our community have been vaccinated. And, you know, the way US is going, I don't even know whether we can get there because there are this group of no vaccine people who are just kind of saying stuff that are just nuts. Right.
Well, there's always going to be that set because we have mothers now that will not vaccinate their children until they get that particular virus, and then it's like that random time where you're like, oh, well, I thought we eradicated this, but there's this one child with it because they didn't get vaccinated.
Absolutely.
Go ahead.
No, go ahead. You're fine. Yeah.
I was going to say, it's going to bring me to the next question in the chat, which talks about then why should Blacks really get vaccinated when our comorbidities are high? And I will say that unfortunately, because, and this is from me as a nurse, because in the Black community, we tend to have the blood sugar and the high blood pressure generation to generation to generation is why, again, I think that we probably should get vaccinated. But as you stated, you need to of course, go hand in hand with your physician. So in other words, this is an informational session that is saying the benefits of the vaccine. Yes, you do have comorbidities. It's higher in the Black community. But if you walk hand in hand, meaning your physician knows you have the this plus the this and can check your lab work, then they can flow from there with regards to whether or not you should get the vaccination. Am I correct?
Yes,
absolutely.
You're correct.
Yeah,
okay.
Absolutely.
A question, and because you guys are in the medical profession and you already can see where the vaccinations are, a question was asked, when will the governor, and that's of Florida, open up the vaccines to other age groups? And maybe not just in Florida, but maybe anywhere. Do we know when the possibility, and now I know Fauci said something about April, but do you see it happening that quickly?
I see it happening that quickly nationally. I just don't know what our governor is doing. You never know what our governor is doing. So I can't even say with our governor. Because, you know, and that's the reason why is really, you know, there's been some suspicions that some of the vaccines that are coming to Florida, they're they are sort of like targeting some communities or targeting places. So it depends on what is coming on. And he wants to show that he's not necessarily going with the plan of Biden, because they are not from the same political thing. So as is a little bit, but hopefully by April, it would be something that can be opened up, hopefully.
So we will then maybe have to lean more on the CDC and like Fauci and his team to kind of get the answer as to when the next level of age groups might get vaccinated. Because I don't think it's just Florida that's not getting under 65 vaccinated. Am I correct?
Yeah.
Right.
It's across the board, right?
Yeah.
Yeah, but you have a couple of different things going on. So the CDC makes a recommendation in terms of the age group and who else. But then some states actually haven't gotten their vaccine allotment. So each state kind of decides what that next tier of persons are. But then again, if you don't have the vaccine, you can't vaccinate people.
Can't vaccinate, right. Yeah, because even in Florida, I'm hearing that they've even held back because they need to hold on to the second dose for the others, for the set that got the first.
Right.
Do we have statistics on how many people have actually recovered from COVID-19 in Florida?
I looked at the Johns Hopkins website today and I didn't see that number.
Yeah. You only have the death rates and.
Right.
Yeah.
Okay.
Right. A lot of the data depends on what's reported. I didn't see it today on the Johns Hopkins website.
Okay.
Yeah, and the other thing to know about that is that there are quite a number of people who had mild COVID and really is not included even in because they didn't even know. I mean, it's kind of sort of mild. So getting those statistics would even be an estimate also. So, but the hospitalization, would be,
okay.
And death rates would be something that you have.
Okay. Somebody else made the point in the chat that, especially for our community, it's almost like planned failure when they do put out, okay, sign up for this vaccine, but there are people who don't have computers and are expected to register online. So that's another hurdle that we have to go over, that people who are not technologically savvy has to try to sign up in some way, some form. And so even getting things to an HBCU or something as simple as getting it to a Walmart is a lot more simpler if we want more people vaccinated. It's a lot more simpler and it makes more sense if we want a higher rate of vaccinations.
Yeah, we have to take it to where people are. I mean, this is
Exactly
why we have disparities, right?
Right.
We have to take it to where people are.
Right. Another question, how do we protect children under 2 years old since they are not to wear masks? And I will say that I've seen 9-year-olds and 12-year-olds die, but I haven't heard anything in the baby to 2-year-old range. Are there any statistics on little kids, toddlers catching COVID?
There are.
What do we do?
Yeah, there are, but they're not as, the mortality within that group is not really as high. The way to protect them is by you blocking the virus from coming to them. And you get vaccinated, you use masks, you protect them, don't bring it home. And that's the only way you can right now. And making sure that the daycare that they are in or where they go to, they are taking the appropriate precaution and they are wiping down and they are, so for example, my grandchildren, one is 2.5 and the other one is a baby. The daycare that they are in, they make sure that they are not very near each other. And they make sure that everything is wiped down and everything is so well done. Parents cannot come in to get their kids. The kids are brought out to be able to get them into the car outside. So you have to and there are CDC guidelines that talks about that, and this is one of the reasons why we talk a lot about, please get vaccinated because it's the only thing that is blocking you, and then continue to wear your mask because you can still be infected and be a carrier. So when you're infected, you can still be a carrier, right? So you have to still do the masking, the washing of hands and social distancing and making sure that you don't bring it home.
Okay, this is our final question. And I pretty much have an answer to this because the church has partnered with Jackson Hospital and the Community Health Incorporated Clinic, CHI. to assist in just making people aware of when vaccines are available, COVID-19 vaccines. It says if a person under the age of 65 and they have underlying conditions, are they eligible for the vaccinations? Now, I know that we were told, yes, they are, but the problem is that according to the governor, they're only vaccinating 65 and over. So it's not that you're not eligible, but it's that your time for vaccination is not now.
That's
Am I correct?
That's
Yeah.
correct.
Okay.
I just really want to say thank you, everybody. I have to leave for another meeting at 4 o'clock. Thanks so much. It's an honor to be here. Thank you very much.
Thank you, Dr.
Thanks.
Odedina. I was so happy. We're so happy that you were with us. Blessings. Yes, so thank you for answering that question. So yes, it's not that you're not eligible, but until the governor and everybody else, because it's not just Florida, has eased up from the 65 and older requirement, they're not allowing anybody else. I've even had people call to say that they have a doctor's note to say that they're eligible for it, but unless you're a nurse or some kind of essential worker in the hospital, if you're not in that category, you're not going to get the vaccine at this time until they open it up to 65 and under. Okay. I hope that everybody's question was answered. I want to say thank you again on behalf of Bishop Joshua Cayley, our District 1 Overseer, and Sherry Dyer, our District 1 Medical Team Director. Thank you so much, Dr. Rule and Dr. Reagan. And Dr. Odedina, your knowledge was vast. I think that we can safely say that everybody on this panel is well educated. You guys are subject matter experts. And I have to say, everybody who joined today can say that they're leaving that much more knowledgeable about the vaccine, about the virus, and about even the health disparities within our communities as African Americans. Thank you, thank you, thank you. Everybody, thank you for joining us as well. Thank you for your questions and remaining engaged. I hope that we were able to answer something. If you have additional questions, please send them to us. We'll get to Dr. Reagan, Dr. Rule, or Dr. Odedina, and I'm sure they'll be happy to send a response. Thank you, thank you, thank you. We're gonna close with a word of prayer. And again, I'm hoping that the knowledge has given you something to really think about. It has dispelled some of your fears, and that you'll move forward however you will. And again, as they've continuously said, get with your health care practitioner, get with your doctor, discuss it with them, find out what you have going on with you and what their thoughts are on the vaccinations as well. Thank you. Father, we thank you for today. Lord, you said to study to show ourselves approved. And while we didn't study, but we sat at the feet of some knowledgeable individuals, subject matter experts in this time. I thank you, Lord, that we're leaving this place knowledgeable. We're able to make decisions, dear God, not just based on assumptions and fears, but because, Lord Jesus, you gave us the opportunity to learn and to learn it well today. I pray, God, that we'll leave here making the right decision, that we'll pray about it, and we'll join in with our health practitioners, and again, use the knowledge that we gained today to move forward with our health choices. We give you thanks for our panelists, Dr. Rule, Dr. Odedina, and Dr. Reagan. May you bless them, continue to give them strength, dear God, as they move forward, dear God, in helping our community, dear God, during this pandemic. Cover them and cover each individual on this line, dear God, we pray. We give you thanks, we give you praise. Lord, go with us as we separate from each other today. In the name of Jesus, amen. And amen, amen. If you guys want to open up your Zoom line and just tell our panelists, thank you. Just let them hear your voice and let them know that you appreciate.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you very much.
Thank you very much.
God
Thank
bless you
you.
guys.
God bless you all.
Bless you all.
This was
Yes.
very, very informative.
Yes.
Thank you.
Awesome.
Thank you so much. We wanted to just help during this time, and we couldn't have
Thank
done it
you.
without you guys. Thank you, thank you, thank you.
Awesome, awesome.
Thank you.
Thank you.
Y'all have a wonderful afternoon. Thank you very much. God
You
bless
too.
you.
God bless.
And we will get with you, Dr. Reagan, Dr.
Yes.
Rule, and Dr. Adedina. If we have any more questions, we'll definitely shoot it your way. And if we need to do this again, we hope that we can call on you one more time.
Thank you. My pleasure.
Thank you, guys. Have a good
Bless you.
afternoon. Take care.
Okay, take
Bye-bye.
care. Bye-bye.